Hi everyone, this is Professor Ken Ed, and today I would like for us to look at selective serotonin reuptake inhibitors, SSRIs for short. Now, what are SSRIs? SSRIs are a group of antidepressants which work by selectively inhibiting the reuptake of serotonin in the brain. So when you look at the name, they are called selective serotonin reuptake inhibitors. And their work is to selectively inhibit reuptake of serotonin in the brain. Serotonin is known as a neurotransmitter that is very important in regulating our mood, amongst other functions in the brain. And so these drugs help in ensuring that serotonin can do what it needs to do in order to improve mood. But how does the drug really work? So if we say that it selectively, or this class selectively inhibits reuptake of serotonin, what does it mean? I would like to do some illustrations very quickly, and then we can continue. So let's pick the terminal of a presynaptic neuron. Let's assume that we have some vesicles with neurotransmitters in there. So in this case, the neurotransmitters are serotonin, all right? And then we have exocytosis taking place to allow for the release of these neurotransmitters. Now let's also bring in a postsynaptic neuron with its receptors. Let's change the color to red. So with its receptors, postsynaptic receptors here. All right. Now, when these neurotransmitters are released, we expect that they will be able to bind to receptors on the postsynaptic membrane, okay? And their action on these receptors would help to improve mood. But after they've acted for a while, these neurotransmitters are supposed to be shuttled back to where they came from. They go back to the presynaptic neuron. And there are transporters that do this. In the case of serotonin, the transporter is known as SET, serotonin transporter, okay? So SET carries the neurotransmitters or the serotonin back to the presynaptic neuron. And when this happens, it means that the activity of the serotonin is going to decline. Now, in depression, one of the problems could be that the levels of serotonin, the concentration of serotonin is reduced, or the activity is dysfunctional. And so as we continue to take out or to take up the serotonin back to the presynaptic neuron, we are going to reduce the amount of serotonin that we have in the synaptic cleft where I'm circling. And so as we reduce the amount, it is going to affect the person's mood. And so in order to address the depression, one of the things the SSRIs, or what the SSRIs will do, is that they inhibit this transporter. They inhibit this transporter that is supposed to do the reuptake. So as we inhibit the transporter, it means that the serotonin the shuttling of serotonin back to the presynaptic neuron will reduce. So we'll now have accumulation of serotonin down here, which will then allow us to be able to have more activity from the serotonin. So the serotonin will bind to the receptors down here. Now, whilst this can happen on the same day that we gave the SSRIs, the mood does not improve right away. There are certain changes that must occur on the membranes of these neurons, okay? Certain adaptive changes that we call synaptic plasticity. Those changes that occur are responsible for the improvement in the symptoms of the patient. And so this is why when we give SSRIs and other antidepressants, usually the effect does not start right away. You would have to give the drugs daily for weeks before the patient begins to start seeing the improvement in the symptoms. I hope this makes it quite simple to understand. Now, let's look at some examples of SSRIs. So the prototype fluoxetine, which was the first one to be introduced, I guess introduced somewhere around 1987, then or approved somewhere 1987. And then we have paroxetine, we have sertraline, we have citalopram, we have escitalopram, and then fluvoxamine. The brand names are in bracket, so fluoxetine, Prozac, paroxetine, we have Paxil, sertraline, Zoloft, citalopram, we have Celexa, escitalopram, we have Lexapro, and then fluvoxamine, we can have Luvox. Aside using the SSRIs for depression, what else can we use them for? So one, we can use them for depressive disorders, various depressive disorders, especially major depressive disorder. Then we could also use it in anxiety disorders, where you could look at generalized anxiety disorder. You can look at panic disorder. We could use it in obsessive compulsive disorder, right? And so post-traumatic stress disorder, we could use SSRIs in this. And in fact, they are considered first-line drugs in both depressive disorders and anxiety disorders. We could also use them in eating disorders, chronic pain, and then depersonalization disorders. So these are some of the main uses of the SSRIs. I hope this is something you can easily remember. Now, as I said, SSRIs are the first line drugs for managing depressive disorder and anxiety disorder. Now, what makes them that popular? You know, prior to their introduction, we had the tricyclic antidepressants, and then we have the monoamine oxidase inhibitors. But these drugs were associated with very pronounced adverse effects. But because there were no other alternatives, they had to be used. But with the introduction of the SSRIs, the realization was that they were safer, and then they were more tolerable for the patient. And so unlike the TCAs and then the monoamine oxidase inhibitors, the SSRIs had lower incidence of adverse effect. Not that they don't have adverse effects or side effects, but they had lower incidences of that. And in terms of the severity, it was quite manageable. And then they were more tolerable for the patient. In fact, we consider the SSRIs to be devoid of most of the side effects associated with the tricyclic antidepressants. Again, they do not affect conduction of impulses in the heart, so they may not cause arrhythmias. They are considered very safe in people with heart conditions and the elderly. So you realize that this makes it quite safe for us to use. Now, I mentioned that the fact that we say they are safer and tolerable doesn't mean that they do not have any adverse effects or side effects. So let's quickly address the issue of their side effects. So we could think of side effects in terms of gastrointestinal side effects. Here we have nausea and diarrhea or loose stools, and we could reduce this by making the patient start from low doses and then taking the drug after meals or with meals. That reduces that gastric irritation, right? Then we could also have CNS, that central nervous system adverse effects. Here we can have agitation, we could have anxiety, and then we could have insomnia. With relation to that agitation and anxiety, normally starting with a low dose can help. And we also have some information from research that as the patient continues taking the drug, most of these side effects subside along the way. With the insomnia, normally what we do is that we would advise that the patient could take the drug with some sedative hypnotics if the drug has to be taken at night. But assuming the drug is supposed to be taken once a day, then taking it in the morning would ensure that the tendency for causing insomnia is far reduced. Then we have the sexual dysfunction, where about 33% of the patients may experience this. And this could be in the form of decreased libido, delayed ejaculation, and anorgasmia. So aside these adverse effects, generally, we consider the SSRIs to be safe. Now, the next thing I want us to look at. So we want to look at drug interactions. Now, these SSRIs, normally as we administer them to our patients, they could interact with other drugs. And one of the reasons why they do that is because they inhibit cytochrome P450, 2D6. Now, aside citalopram, the others usually would inhibit cytochrome P450, 2D6. And if you have other drugs that the patient is taking, and those drugs are supposed to be metabolized by this enzyme, then the chances are that the drugs would not be metabolized quickly and they may accumulate, leading to toxicity, especially if those drugs have narrow therapeutic index. So for instance, type 1C antiarrhythmic agents. These drugs, for instance, we have flecainide, we have encainide, and then we have propafenone. These drugs already have very severe adverse effects. And so if you were to give them together with, say, fluoxetine is going to inhibit cytochrome P450, 2D6, which is responsible for metabolizing the type 1C drugs. And so they may end up accumulating, leading to more toxicity. The same thing happens with antipsychotics and tricyclic antidepressants. So it's necessary you know which drugs may interact with the SSRIs, so that if there is a need to adjust the dosage, we are able to do that. Lastly, we can look at a summary of what we've said so far. And so we've said that SSRIs are drugs that selectively inhibit serotonin reuptake. They are safe, they are tolerable. We consider them to be first-line drugs for depression and anxiety disorders. We could also use them in depersonalization reaction, disorders. We could use them in eating disorders and chronic pain. We've also mentioned that there are some few drug interactions to look at. And I think that this makes it a little bit simple for us. And I hope to come your way again with another class of antidepressants. And until then, this has been Professor Ken Ed. Don't forget to subscribe to our YouTube channel for more videos. For now, bye.